So good afternoon, everyone, and thank you very much, Karen, for the invite. So I'm going to very briefly run through our experiences in the UK with regards to the most recent COVID pandemic in the last year. I work in a city called Birmingham, which is the second largest city in the UK, and I'm a critical care physician as well as a respiratory physician, and I'm affiliated to the university there. So, I mean, going back to around mid to late February last year, we were preparing for the COVID tsunami. And we'd started to hear, as you all know, at the end of December 2019, of the virus starting to make its way across Europe and initially hitting Italy. We had our first actual hospitalized case in the 1st of March 2020. And this is a sort of timeline of what happened in the first period of the initial phase of the pandemic. We'd started to hear of the mysterious illness that was hitting people on the ferries, and the small number of cases that were infiltrating the country in February and early March. And these were the sort of newspaper headlines that we were 14 days behind Italy, and when were we going to wake up to what was coming our way? Within the health service and the hospitals, we were very well aware and worried about what was coming, but it didn't seem that our government was quite ready for it. As I said, I work in a city called Birmingham, which is right in the middle of England there in the United Kingdom, and it's a big metropolitan city. And I work in a hospital called the Queen Elizabeth Hospital, which is part of 4 hospitals which make up one big, what we call a trust. And we serve approximately 2.5 million people in the city. And the Queen Elizabeth Hospital itself is a large tertiary centre. So it has transplantation, cardiac services, hematological services, some specialty surgical services. So really, it's the centre of where most people within the West Midlands, the region that we cover, get sent for specialist services. We have a very large intensive care unit of approximately 100 bed spaces, but usually this is funded to around 60 bed spaces. We were being told by the Imperial College metrics that we and NHS England and the government were telling us to be prepared for at least 500 ventilated patients and possibly up to 1,500 between our 3 hospital sites. So obviously we were in panic mode. How were we going to do this? And what was our priorities, and where were we going to manage the patients? So the first thing we thought about was staffing. Obviously, we don't have enough staffing to cover that many patients, and where was this additional staff going to come from? And we really used members of staff from all across the hospital. So we redeployed staff from other medical specialties, surgical specialties, outpatient specialties. This is both nursing staff and medical staff. And we had a very rapid sort of 2-day training period. And the way that we were going to look after patients was sort of 3 to 6 patient pods, where you have at least one person who has some training in intensive care medicine looking after those 6 patients, one nurse who was a specialist intensive care nurse in that pod, and then junior non-specialist members of the team, then building up that pod, and then a senior trainee or senior consultant overseeing a number of those pods, and then a sector lead or a sector commander looking after a whole unit. Now, we felt that was the best way to try and manage things, a bit like a major incident. The next thing, we were worried about oxygen, and even before Birmingham started to see a big wave of patients, we'd already seen in London that there were some smaller hospitals that were having to be rescued because their oxygen supply wasn't adequate, and they were running out of oxygen. So we made sure within our infrastructure that the oxygen supply would be adequate where we were going to house the patients. And this, fortunately for our new hospital, for the intensive care, wasn't going to be a huge issue. We had a whole plan of our estate and where the patients could be managed, where they could be moved, how we would escalate the number of patients. So we have one big floor of an intensive care unit, separated into 4 separate units. And we decided we would start on one end and work through the unit and start building the number of COVID patients, pushing out the non-COVID patients into a new part of the building. We started to clear out theatre space and anaesthetic rooms to manage patients in. And we also started to double space, so we were putting two patients into a space designed for only one patient. At the same time, the government and NHS England started to build these large, what we call Nightingale hospitals in stadiums and exhibition centres. These were built within a week to 10 days. And the sourcing of ventilators and equipment was all done centrally by government and NHS England. Fortunately, we never had to use these for any significant number of ventilated patients. However, we did use some areas for outpatient services for a very short period. The most important thing that we learned was that this was a multidisciplinary way of working, and we had to utilize all the skills from pharmacy to physio to management. Anyone that had any skill was pulled into the planning and the preparation, as well as the care of the patients. We tried to maintain our education program throughout this. We had an expedited training program in critical care for non-critical care specialists, non-critical care doctors and nursing staff. And we tried to maintain at least a weekly educational program. Ventilators, we obviously looked through our entire trust and managed to source all our anaesthetic machines from theatres, as well as the ventilators that we had within the intensive care unit. But we managed to get 200 of these Chinese ventilators, which our medical engineering team worked on for 48 hours to make sure that they would work. Now, these aren't ideal, and we didn't really want to use these until we got into a situation where we were really running out of any other options. I think in the end, we only ended up using about 10 of these, and they were really not very good. This was all, again, helped by resources centrally from government and NHS England. So PPE was a really important and integral part. We were very clear from the beginning that looking after our staff was paramount, and we needed to make sure that our staff was kept safe. We had donning and doffing stations, so areas where we had dedicated members of the team, or what we call donning officers and doffing officers, to make sure people were putting on their PPE appropriately and they were taking it off appropriately. We know that the biggest period of contamination with the virus was in the doffing, so in the taking off of the PPE, when you contaminate the area around the face, nose and mouth. We built in a major incident plan, really, and we had a command and a structure, and we were having daily meetings 3 times a week because things were so dynamic and moving on a constant basis. Things were changing. We were running out of, for example, filtration machines and pumps, and we started to mix, for example, midazolam and morphine together in one bag to reduce the nursing burden. But we really went away from our normal working practices, but this was all done in a very organized manner. So we'd have a meeting first thing in the morning. We had bronze, silver and gold command meetings that went all the way up to the chief executive of the trust and the hospital, who was linking in then with NHS England and the advice that we were being given from government. How we worked on the floor on a day-to-day basis, we had dedicated teams, and we realized that this was the way we were going to be able to manage patients the best way. We had what we call COVID assessment teams. These were dedicated consultants who went out and outreached patients on the ward and decided whether a patient was needed admission to intensive care unit and whether it was appropriate to admit them to intensive care unit. Throughout the big surges, we had an only intubation admission to the ITU, so it was only if you needed a ventilator invasively that you would get admitted to the intensive care area. During the sort of middle areas between the peaks, we did have patients who were on non-invasive ventilation on the unit. We had a dedicated intubation team that was made up of senior anaesthetists 24/7, who once, for example, if I went and saw a patient and said that, yes, they needed to come to ITU, they would go to the ward, they would intubate them at the bedside and wheel them to the intensive care unit. We had dedicated, so here you have an intubation team. We had dedicated lines team. So once the patient arrived on the intensive care unit, there was a team who came in with their lines kit and came in and put in all the central lines and A lines and had the patient ready really to go. Proning was a huge management plan and we used this very, very regularly. At some points during the pandemic, we had around 70 to 80 prones a day happening and D-prones a day happening. So we had a dedicated team made up of theatre staff, scrub nurses who were trained on proning. We did tracheostomize many patients and we had a dedicated tracheostomy team that was made up of max fax and ENT surgeons who came. Our physio team were integral to both the rehabilitation of the patients, but also lung protective ventilation. We initiated whiteboards behind every single patient with their lung protective parameters, and the physio team had the jurisdiction to go in and change the ventilator parameters to ensure that patients were being kept within lung protective parameters. We did have to transfer patients between hospitals within region, and actually at the worst in the second, or what we would call the third wave in the summer, in the winter between January and March, patients outside of our actual area and region to all the way south, down to London, up to Scotland. And this was again driven by NHS England. Fortunately for us, our intensive care beds are managed nationally, so we have a certain number, and so it's not just down to the hospital. You could never say that there is no ITU bed until the last ITU bed in the country has been utilised and the patient's been moved around. So we transferred patients not only within our own hospitals, but also outside of region. And there was a dedicated team for that. I already spoke about the donning and doffing teams. We also had what we call cares team, and they came and did mouth care, helped with the cleaning and washing of the patients, and ensuring that pressure areas were maintained. Importantly, we had no family visiting during this time. And so if we were to, as the medical team, as we normally would, call the patient's relatives every day, then we just wouldn't have time to look after the patients. So we had members of medical staff, consultants, all the way down to medical students who were the family liaison team, and they would make contact with the patients' families every day to give them a brief update. They were trained on the important information that needed to be given to the patients. Obviously, if there was a serious decision to be made about withdrawal or limitations to care, or if patients were end of life, then the consultants or the doctors would call the patients' relatives. Most importantly, this was a team effort, and it required pharmacists, cleaners, estates, so people trying to find pumps from us. I mean, we were, going to the airport, trying to intersect where pumps to deliver medication might be from. So this was all done in a very team fashion, and that's the only way we really got through. The other thing we had very much clearly in our minds that we would maintain protocolized care. There is no way you can look after 200 ventilated patients if there's all sorts of varying management going on. So we had clear guidance on ventilator management as well as other structures, how we would be delivering medication, nutrition, and renal replacement therapy. We went to a model of just intermittent 4-hourly CVV-HDF rather than continuous filtration, because there was just not enough filtration machines around. We put all our faith into research, and fortunately for us, the NHS and the NIHR and UK research was thriving really, and they very quickly, a lot of the big trials were set up within a matter of days, and you all know that the steroid success. We knew already by sort of mid-April that steroids were useful in this. We did not use anything that was experimental or outside of a trial. We use standard, good intensive care medicine, lung protective ventilation, proning, and fluid management, just general ITU care, and we only really recruited patients to trials. There was no ad hoc use of other interventions, pharmacological or otherwise. So this was how things have worked out over the last sort of 18 months. We had our initial first peak around April is when we probably peaked, and then we had this drop down of our cases, and then had a small wave in September, October, November time of the end of last year. But as we opened up and the country opened up and lockdown restrictions were released, we had this huge and actually much worse wave in January, February and March of this year, in many ways worse than the first wave early last year. This was the number of cases admitted up until the end of August last year, and this is since August. Fortunately, in the last month, the number of cases have been reduced right down, and this is despite the community cases massively rising over the last week or two. This was our total number of admissions at our hospital, at just our one single hospital, QE hospital, and we've had over 700 patients into the intensive care, and the majority of these were ventilated. Our average length of stay for survivors is around 21 days, and if you look at our ventilated survival, so ICNARC, we're lucky as well in the country to have a nationalised database of outcomes on all patients admitted to intensive care, and they were giving us weekly updates on how patients were doing and what our outcomes were. You can see here that in the first wave, between February and May of last year, mortality was around 50%, whereas our mortality sat around 33%. We had this mini wave in what we call the second wave until December 2020, and here our mortality was a bit higher at 42%. And I think this is when we were admitting a slightly different cohort of patients because we had much more capacity to do so. But the last wave between January and March, we've really improved our management, and our mortality is reduced right down to around 25%, which is much better than the national, which sits at around 38%. So when we've reflected on this, what we've really realized is that it was all about being prepared, about the leadership that was put into place. We had very open, robust discussions, and sometimes we didn't agree. In the initial phases, everyone wanted to anticoagulate everyone because there was this whole talk about thromboembolism being a major part of the pathophysiology of COVID. But we really stuck to our philosophy that we would not do anything outside of evidence-based medicine. We had very clear protocols, excellent colleagues. We all got together and really worked together very well together. We really focused on the donning and doffing and looking after our staff. And actually, the intensive care staff had only a 5% sero conversion when we did this, when we measured their antibody levels in sort of May, June time, compared to housekeeping, who had about 30%. And we really focused our minds on research and recruiting patients to clinical trials. And one of my colleagues, when we were really, really struggling, and what we said to ourselves, this is what it is. It's nothing else. There's nothing we can do about this. We just have to get together and get through this. And now when we're worrying about potential further waves, what we say to ourselves is we did this once, we did it twice, and a third time, and I'm sure we can do it again. Again, we're very lucky in the United Kingdom, despite a lot of the mistakes that we've made, both by government and other reasons, that we have a national health service. So it's a very coordinated national effort where both equipment, beds, and strategy is unified. So we do the same thing across the board. So that's really my sort of my reflections on my experience over the last year and some of the UK experience. I'd just like to end on saying that all normal trials and other non-COVID trials stopped during this period, really, in the UK, and I'm sure everywhere else as well. But fortunately, we're back on track, and I'm really proud to be part of this study that's being led by Karen and Gratz. And the UK have opened some sites and have started recruitment to the trial. So that's great news. Thank you.